We're going to talk about one of my favorite topics, and some of you may have heard me talk about before, the mood and behavior issues. We're going to talk about the use of the guidebook. The mood and behavior problems, the neuropsychiatric problems, are among the uh, most influenceable symptoms that we work with families and individuals on. So absolutely can make the difference between being able to cope with these diseases and not when we work on these well. So let me just talk a little bit about the guidebook. So we created a guidebook that actually is a framework of how to think about the symptoms and really replaces this, what I consider to be a myth of hopelessness around these mood and behavior problems, this myth of, gosh, it's just part of the disease. Yes, we are vulnerable to mood and behavior problems if we have a dementia. That does not mean that they are unremittable. That is not to say they're non-influenceable. That is not to say that there's not external contributors or other puzzle pieces that need to be dealt with. So for us, the guidebook gives a framework to combat that flawed thinking and to replace it with, just like any other symptom, we must consider it a puzzle that we can make an impact on. And when we position it that way with families and individuals, then it increases a sense of control. And ultimately, what we want to do, whether it be the person with the disease, but most especially in these middle stages when the mood and behavioral problems are more common, we want to impact caregiver confidence. We really want for these caregivers to feel like, okay, I've got some tools, I've got some things to do. It's the guidebook is not a narrative. People don't want to read. That care partners get overwhelmed when they get big stacks of information. It drowns them. It almost adds to their sense of being overwhelmed. So we don't want additional narrative. And when we think about ourselves as providers and clinicians, our time is pretty precious too. And so it's not a narrative, it's bullet points. And it can be shared with others and facilitate those therapeutic discussions. And by that, I mean provider to provider. Some of you may be in facilities, for example, or working with other teams of clinicians. So there are 3 sections in the guide, and we're going to look at it here in a few minutes. So there's these 3 broad areas. So you go to the first section first, which really looks at the common mood and behavioral challenges. And that section is important because we don't put the label to all of those mood and behavioral challenges. Sometimes when people think of neuropsych challenges or these behavior issues, they straightforward think about agitation. And there's so much more to it than that. And so it really looks at the array of mood and behavior challenges. And then the second section are contributors to those challenges. And so as we look at the guide here in a few minutes, we may think to ourselves, for example, well, the behavioral issue is exit seeking. And we might just automatically assume, well, they're not safe to stay at home anymore. Or we might just assume that we need to secure the doors. And maybe we do, but maybe there's other things. So it looks at the second section, looks at all the possible contributors so we can go through that thought process and consider those kind of possible interventions. We jump too quickly to interventions before we kind of thoroughly analyze what's going on. And then intervention. So if we narrow it down to say, in the case of exit seeking, that's what's happening is that there's there's paranoia or some level of hypervigilance that is demanding that is pushing them to run from. They're trying to get away from a unsafe situation. So then we are really addressing the paranoia rather than the exit. The paranoia is driving the exit seeking. So there's a set of interventions we would then address or attempt. So as we look through the neuropsych symptoms, we want to think about it in these kind of ways in terms of possible support for you. One is that it might give you possible considerations. We all know that the interventions and even the contributors are virtually unlimited. We have to know the person and the situation. So this guidebook is not a finite document. It doesn't give us all the possible reasons or all the possible interventions, but perhaps it lends itself to considerations we wouldn't have thought about before. It allows us to talk through with families. Families can hear, but they don't always hear. They're operating at a level of being overwhelmed, especially when we're dealing with mood and behavior problems. That's the highest stress area for families. It is the time when those symptoms present. It is the highest risk for depression in family members. So having a concrete visual can help. We can talk through with care team, and that might include home health, that might include facilities, it might include in-home respite care providers who I think probably most of us would agree do not get sufficient training and don't really know some of those answers. So really embracing that we're supporting everyone involved in that person's life. We're trying to increase quality through all of us being as informed as we can. And of course, it can be utilized in care planning and reference. So when we think of this as a care tool for families, not only can it increase that building of confidence as we talked about, but it also can validate your assessment and concerns. So it affirms perhaps what you are saying. And I know we have a variety of disciplines on the call. So it can validate some of what you're saying. So it's just part of those conversations. It can also be a mechanism to address family conflict. And guess what? We have a lot of families who see things a lot of different ways. And it plays out in pretty tough circumstances, and it plays out in pretty diminishing circumstances at times. So to address that family conflict and get people on the same page. And it can also be used as a tool to address areas of denial. And let me just give you an example of what that might look like. For example, there are families who will test their loved one in middle stage. Now, you know who I am, you know what this is, you know who this visitor is, those kind of things. They're testing, they're doing that because they think somehow that they're giving the person brain exercise. I've heard that many, many times. I want to I want to keep their brain thinking. And what actually happens for many people in those situations is they get that lost look on their face. They can get agitated. They can get frustrated. They don't know. We can see the rise of what I call performance anxiety. So that testing can actually have a negative effect, and in fact does for the majority of people who attempt it. Not all, but most. And so really looking through that, and that's one of the things that is articulated in the guide, can help break down, no, we're not really doing brain exercise, we're really contributing to some agitation or anxiety. And, there are other areas where families, out of a desire to preserve the integrity of who the person was, that they put individuals in situations that actually feed anxiety and agitation. So looking at that. And there's also a conversation in the guide about therapeutic fibbing. We all talk to families about that at a certain point in the disease. In middle stage, it becomes very important that we no longer rely on logic in our conversations, that we no longer try to convince people of things, and that those conversations are in the neuropsych guide. I visited with a patient or a daughter just the other day about a woman who's quite middle stage Alzheimer's disease. She was diagnosed late in the disease process. She's struggling with putting clothes on. She's putting clothes on inside out and backwards. She's a very dignified woman and has no idea of these kind of errors or deficits. And the daughter continually tells her she really believes if she can get through to her that she has Alzheimer's disease, that a lot of this stuff will change, that she just needs to break down the denial of the woman diagnosed. And of course, you and I know we need to break down the denial of the daughter who is coming to understand that the part of the brain where insight and executive functions live is damaged, and to expect mom to understand and make decisions based on that understanding is unrealistic, and again, feeding some of the behavioral problems. So families need to help. They need that guide, that direction, and this becomes a tool. It also becomes a opportunity for advocating. So, we can support our peers in becoming more dementia capable. That is a limited set of people who are dementia capable and competent, and that's not an indictment. We're busy people. We all have different levels of expertise. We all got to help one another. So, the guide can be a support. For example, in my world, oftentimes I'll talk with other therapists who have clients that are dealing with family members with dementia, and very competent therapists. They are working on loss and depression and all kinds of things, but they don't know much about dementia. So they call and talk with us, and that's great. And we give them the resources, and this is one of the resources we give them. So not an indictment. We're all in this together. We all need to share information. This is just another piece of information that we can share. And then really contributing to the empowerment of families as a whole. We cannot feed this myth of it's just part of the disease and you live with it. We cannot do that. It dismantles the ability of the caregiver to move forward, and it keeps them locked into interventions that may be more harmful than helpful, maybe more harmful than neutral. So we need to facilitate this an empowerment model that really helps them build, okay, here's some things I can try. I tell people every day, this is a exercise in trial and error. We never know what works for a person. Whole people all the time, and they bring forward history, and they bring forward resources, and they have different levels of cognitive reserve, different levels of social graces, um, different personalities and coping strategies. So we can't predict how anything would work. But we need the tools in the backpack. So in terms of the guide, and I'm gonna pull that up. We have the PDF available on our website. We have a hard copy that available if needed. We don't have an unlimited amount, but we have some if people need to pick up. This is a old slide. We actually have a Apple and Android app that can be used. And the organizers can put those links in the chat if they would. I'm going to pull up the guide itself. I can grab it right quick. Where is it? I had it pulled up. And I'm not seeing it. I'm not seeing it.
Michelle, let me send that link to you real quick.
Oh, here it is. Let's see if this works. Yeah, oh, here we go. Okay. So the mood and behavior guide here. Hopefully people can see. Let me move this out of the way.
We can see your screen.
Okay. So it begins with this section 1 that is just general, very brief conversation about dementia. And then it goes into these common mood and behavioral challenges. So you can see a number, and it gives families and providers the opportunity to, for example, gosh, my loved one is struggling with repetitious questioning, and I don't know what to do about it. It's driving me nuts. I get frustrated. I yell at the person because I'm so frustrated, and then I feel guilty about that. So then we go to page 17, which is in the next section. And we're going to come back to this section here in a minute. So page 17. So this is repetitious questioning, and so this section really looks at what might be possible reasons for repetitious questioning. Again, you can say, gosh, just part of the disease. No, again, vulnerable because of the disease, but there's reasons why that happens. And so we look at possible contributors. So boredom is a possible contributor. When people are bored, you often hear this repetitious questioning about, what do we do now? Where do we go? Do we go to the doctor today? Is she coming over today? Or do we go to the gym today? We hear those kind of questions because of boredom, or even more fretful about, do we have enough? What am I supposed to do? Those kind of things. It can be evoked because it's away from safety zone. meaning that the repetitious questioning begins when they're in groups or they're away from the home or they're driving in the car. So when repetitious questioning happens matters. Is it all the time? Is it within certain situations? Depression. And when people say they're repeating themselves all the time, I always ask, what are they repeating? Tell me how that goes. Because repeating and telling me the same story. I had a person yesterday. Every time I really see her, she tells me the same story about this situation with a friend of hers, which was wonderful. She enjoyed it. She felt like she helped the friend. She tells me that same story every time I see her. I'm not worried about that. But the person who says, am I okay? Where do we go when there's this emotion attached, anxiety attached? Then it can be depression, can be overstimuli. When are we going home? Where is the bathroom? So we look at that. It can be external kinds of triggers. In other words, perhaps family conflict, people arguing around, perhaps feeling insecure for some other reason because of the external world. It can be they're just trying to make conversation. In the case of the woman who keeps telling me about the experience with her friend, that's what she's doing. It's part of her, what I call repertoire, and that's okay. It can be an unmet need that they're not able to articulate as that physical messaging disconnect. So it can be, I need to go to the bathroom, I'm hungry, those kind of things. So we're thinking perhaps that it's away from safety zone. So that's page 37. So now we're going to go down to the section on possible interventions. So we're going to assess the level of anxiety. We're going to manage depression. We're going to look at that and see, is there depression on board? And there's a page to look at that to assess. We're going to determine if it is in specific places. We're going to learn to do some other strategies. For example, introduce others that can stay with the individual for small amounts of time when the caregiver is out. So that toe in the water. So that if they're away from the safety zone, a lot of times the safety zone is the care partner, and we need to work on that. We need to address the depression. We also need to begin to introduce people slowly. How we tell people, sharing details about destination and providing resources. We're going to go here. This is what's going to happen. I'm going to be with you. And to some degree, it's even the timing of when to tell people. I've known care partners who would tell people in the morning, the person would stew about it till it happened. So figuring out that timing, and sometimes using visual cues. So, and that's how it goes through all of the mood and behavior challenges, and then things to consider in possible intervention. So you can see hallucinations. What are we going to look at? We can see rapid onset. We're going to immediately begin assessing for delirium or possibly another acute medical issue, urinating or defecating beyond the toilet. We're going to look at that. So all of these are in the guide. Social withdrawal, which, let me tell you guys, is just as much a serious behavioral issue as agitation is. Refusing to eat, hoarding, anxiety piece, hiding, moving things, the anxiety element, sleep disturbance. So the unwanted sexual expressions, resistance. So it looks at all of those things. I want to get back to this page, which I use a lot with families. And that is, when is the mood and behavioral challenge a problem? And or not a problem in this case. So if the severity is low, if the duration is limited, if responsiveness is high, that they can be easily redirected. And if distress is low, then we're not going to worry about it. So someone who gets a little bit testy when you're trying to help them with bathing, but the person can redirect them and reassure pretty quickly, and the bath goes okay, I'm not going to worry about that. Guess what? We all have feelings, and we have the array of feelings. So I'm not worried about the expression of feelings, but I am worried if severity is high. I am worried if the duration is extended. And by that, I mean if I had a husband tell me yesterday she won't take her medications, and eventually she will take her medications, but it's taking him 2 hours to get her to take her medication. The duration is extensive. That's not sustainable. If the responsiveness is low, so we reassure and we redirect, we have all the tools in the toolkit, and it's not working. If the distress is high, if they're hallucinating and have delusion thoughts where somebody's trying to harm them, where they're unsafe, where their family is being harmed, if duress is high, then I'm of concern, and we have to do something. And we can figure it out pharmacologically, we can figure it out non-pharmacologically, often it is both. And some of that is addressed in the guide as well.